All right, today we are going to do a really deep dive into the pharmacology of antipsychotic drugs. You might also hear these called neuroleptics. These are some seriously powerful medications, and they're designed to treat a condition called psychosis. So our mission here is to explore exactly how they work inside the brain to help manage some of the most challenging symptoms in all of psychiatry. So here's our game plan. First, we're going to nail down a definition for psychosis. Then we'll get into the main theory behind it, what's called the dopamine hypothesis. After that, we're going to map out 4 really crucial brain pathways that are involved. From there, we'll look at the nitty-gritty of how the drugs actually work, and finally, we'll connect all those dots to explain their most significant side effects.
Okay, so first things first, what is the actual clinical problem that we are trying to solve with these drugs? We have to start by defining psychosis, which, at its very core, is a kind of disconnection from reality.
So what does that really mean? Well, psychosis is a condition where a person, for one reason or another, starts to lose contact with reality. It becomes really hard for them to tell the difference between what's real and what's not. And it's this fundamental disconnection that antipsychotic drugs are really designed to target.
This disconnection from reality usually shows up in 3 main ways. First, you have hallucinations. These are sensory experiences that feel completely real but aren't actually there. Things like hearing voices or seeing things that nobody else does. Second, there are delusions. These are deeply held, false beliefs that a person sticks to no matter what evidence you show them to the contrary. And third, we see disordered thinking and speaking. This is where a person's thoughts and the way they talk can get all jumbled, illogical, and just really difficult for others to follow.
Now, psychosis can be a part of a few different conditions, but for our purposes today, we're really going to narrow our focus to schizophrenia. This is a major psychotic disorder, and it affects roughly 1% of the entire population worldwide. So you can see why figuring out effective treatments is such a huge deal in medicine. So, one of the most important things to understand about schizophrenia is how we categorize its symptoms. We split them into positive and negative symptoms. Now, this can be confusing. Positive doesn't mean good. Think of it as an addition of an abnormal experience. This is where you see the delusions, which are often paranoid in nature, and hallucinations, which are frequently auditory, like hearing voices. On the flip side, negative symptoms represent an absence or a loss of normal functions. This includes things like withdrawing from social contact, a flattening of emotional responses, something called anhedonia, which is the inability to feel pleasure, and just a general reluctance to do everyday tasks.
And there's actually a third category too. Cognitive symptoms. These have to do with thought processes and behavior. A big one is thought disorder, which can lead to drawing irrational conclusions or speaking in garbled sentences. It can also show up as abnormal or disorganized behavior, like stereotyped, repetitive movements. In some really severe cases, it can even present as catatonia, which is a state of either complete immobility or, on the other end of the spectrum, purposeless and agitated motor activity. Okay, so we've got a handle on the symptoms. Now let's start digging into the why. We're going to explore the leading theory for what's going on in the brain chemistry behind psychosis, and that is the dopamine hypothesis. So where does schizophrenia come from? Well, its origin, or etiology, is really complex. We know it's not just one thing. It's a combination of genetic predispositions and different environmental factors. And we know that stress is a huge risk factor for its development. If we look even deeper, at the neuroanatomical level, what we see is dysfunction in the brain's neuronal circuits. This can mean problems with something called synaptic pruning. That's the brain's normal housekeeping process of trimming away unused connections. And it can also involve an imbalance between glutamate, which is the brain's main go signal, and GABA, which is its main stop signal.
And all of that brings us to the really crucial point here, the dopamine theory. What this theory suggests is that the positive symptoms of psychosis, the hallucinations, the delusions, are driven by an overactivity, a hyperactivity of the neurotransmitter dopamine, specifically at a type of receptor called the D2 receptor. And the evidence for this is pretty strong. We know that drugs that increase dopamine activity at these D2 receptors, what we call agonists, can actually trigger a schizophrenic-like episode. And conversely, drugs that block these D2 receptors, called antagonists, are effective at getting those same positive symptoms under control.
Okay, so to really, truly get how antipsychotics work, and just as importantly, why they cause side effects, we need to look at where dopamine is acting in the brain. There are 4 key dopaminergic pathways that we absolutely have to map out. Understanding these is essential for everything that follows. All right, this slide right here is the key to the whole story, so let's walk through it, pathway by pathway. First up, we have the mesolimbic pathway. Normally, this pathway is all about motivation and reward, but in schizophrenia, the theory is that this pathway is hyperactive. There's too much dopamine. This is what's thought to drive those positive symptoms. So, when we give a drug that blocks D2 receptors here, we get our desired therapeutic effect. We reduce the positive symptoms. Great. Second, the mesocortical pathway. This one's involved in cognition and emotion. Now here, the problem is the exact opposite. There seems to be decreased dopamine activity, and this contributes to the negative symptoms. So you see the problem, right? If our drug blocks D2 receptors here, it can actually make those negative symptoms even worse. Third, we have the nigrostriatal pathway. This is a super important pathway for controlling movement. In schizophrenia, this pathway is working just fine, but when our drug comes in and blocks D2 receptors here, it messes with motor control. This is what causes those awful motor side effects that look a lot like Parkinson's disease, which we call extrapyramidal side effects, or EPS for short. And finally, there's the tuberoinfundibular pathway. Its main job is to put the brakes on the release of a hormone called prolactin. It's also working normally in schizophrenia, but when we block D2 receptors here, that brake is released, prolactin levels shoot up, and we get hormonal side effects like hyperprolactinemia.
And this slide just perfectly illustrates the central problem of this treatment. On the left, you see the mesolimbic pathway. That's our target. That's where we want the drug to work. But because these drugs aren't smart bombs, they're more like blanket bombs, they also hit other pathways, like the nigrostriatal pathway you see on the right. And that is where all those disruptive motor side effects come from. It's the fundamental trade-off of antipsychotic therapy.
So we get the theory. We know the pathways. Now let's get into the drugs themselves and see how they actually target this incredibly complex dopamine system.
Okay, so antipsychotics are basically split into two main groups. You've got the first generation, or typical antipsychotics. These guys work mainly as strong D2 receptor blockers, and yeah, they're good for positive symptoms, but they come with a really high risk of those motor side effects, the EPS. Then we have the second generation, or atypical antipsychotics. Their big trick is that they block both D2 receptors and a specific serotonin receptor called 5-HT2A. This double action not only treats positive symptoms and can sometimes even help with negative ones, but it also means a lower risk of motor side effects. But there's always a but. It introduces a higher risk of metabolic problems like weight gain.
This graph does a fantastic job of showing the really delicate balance we're talking about. Look, on the vertical axis, you have the percentage of D2 receptors that are blocked by the drug. On the horizontal axis, you have the dose. You can see that at low doses, you're not getting much of an effect. As you increase the dose, you climb up that curve into the green zone. That's your therapeutic window, where the drug is working well. But if you push that dose just a little too high, you cross a line into the red zone. And that's where the nasty motor side effects start to kick in.
So let's put some hard numbers on that. To get a good therapeutic effect, you need to block somewhere between 60 and 80% of the D2 receptors. If you drop below 60%, the drug probably won't work. But if you push past 80% blockage, the risk of those motor side effects goes way up. I mean, think about it. That is an incredibly narrow window to try and operate.
The thing about the first-generation drugs is that they're not very selective. They're kind of messy. Sure, their main benefit comes from blocking D2 receptors, but they also block a bunch of other receptors all over the brain, and that's what causes all these other side effects. For example, when they block muscarinic M1 receptors, you get things like dry mouth and blurred vision. When they block histamine H1 receptors, that leads to sedation and weight gain. And when they block alpha-1 adrenergic receptors, that can cause postural hypotension. You know that dizzy feeling you get when you stand up too fast?
Now, the second-generation drugs, they have a more complicated profile. The key thing, as we said, is that they block both D2 and serotonin 5-HT2A receptors. And that 5-HT2A blockade is really clever because it's thought to actually increase dopamine release in that nigrostriatal motor pathway, which helps cancel out some of the motor side effects. But they still hit other targets. Like the first-gen drugs, they can block H1 and alpha-1 receptors. On top of that, they often block another serotonin receptor, 5-HT2C, and this one is strongly linked to those metabolic side effects, the weight gain, high blood sugar, and problems with cholesterol and lipids.
All right, let's pull all of this together in our final section. We're going to focus specifically on the biggest, most significant side effects and link them directly back to the mechanisms we've just been talking about.
The extrapyramidal side effects, or EPS, are a really big deal. They tend to come in two main flavors. First, you have the acute effects that can show up pretty soon after starting the medicine. These include dystonias, which are these painful, involuntary muscle spasms, and akathisia, which is this horrible, uncontrollable urge to move. These are a direct result of blocking D2 receptors in that nigrostriatal pathway. Then there's a much more serious long-term problem called tardive dyskinesia. This develops slowly, over time, and tragically, it's often irreversible. It involves these slow, involuntary movements, usually of the face and tongue. And the mechanism is different. It's like the brain is trying to fight back against the chronic blockade by building more D2 receptors and making them more sensitive. This upregulation leads to these abnormal movements.
And I have to mention a rare but life-threatening reaction called neuroleptic malignant syndrome. This is a full-blown medical emergency. It's caused by an extremely rapid and intense blockade of D2 receptors. The signs are terrifying: extreme muscle rigidity, a dangerously high body temperature, hyperthermia, and blood pressure and heart rate that are all over the place. This requires immediate hospitalization.
And that really brings us full circle to the central challenge of using these medications in the real world. The goal is always to find the right balance, to effectively treat the psychosis while doing everything possible to minimize the burden of the side effects. It's a constant clinical negotiation, a balancing act of risk versus benefit that's unique for every single person.
Which leaves us with a final question to think about, looking towards the future. We know the specific pathway we need to hit, that mesolimbic pathway. So the holy grail in psychopharmacology is this: as our understanding of brain circuitry becomes more and more sophisticated, how can we design smarter drugs? Drugs that are so selective, they only affect that one pathway, giving us all the therapeutic benefits with none of the collateral damage. That right there, that is the challenge for the next generation of treatments.